Assalamu alaikum. Now, now I would like to discuss about a very high yield topic, that is claudication. There are two types of claudication. One is vascular claudication, one is neurologic claudication. Okay, in in neurologic claudication, it is posture dependent. Neurologic claudication or pseudo claudication, it is posture dependent pain, and lumbar extension worsens pain, and lumbar flexion. Lumbar extension worsens pain like walking downhill, and lumbar flexion relieves pain walking while bent forward. There is a sign called shopping cart sign. Shopping cart sign, by which we can diagnose that it is a neurologic claudication. So lumbar flexion relieves pain, lumbar extension causing pain. There is lower extremity numbness and tingling. There is lower extremity numbness and tingling. There is lower extremity weakness, low back pain. On examination, there is normal pulse, frequently normal examination. And as it is neurologic claudication, do MRI of the spine. In spinal stenosis, spinal canal stenosis, this neurologic claudication happens. And vascular claudication happens in Berger's disease or thromboangiolitis obliterans. Okay, it is exertionally dependent pain. Exertionally dependent pain relieved with rest, but not with bending forward or while walking, not with bending forward while walking. There is lower extremity cramping, light tightness, no significant lower extremity weakness possible, buttock, thigh, calf, or foot pain. On vascular claudication, there is diminished, decreased pulse, cool extremity, decreased hair growth, pallor with leg elevation, pallor with leg elevation. And in vascular claudication, ABPI ankle brachial index, ABPI ankle brachial pressure index should be used for diagnosis. Common cause of lumbar stenosis is vertebral osteoarthritis, degenerative disc disease, and thickening of the ligamentum flavum. Now, spondylolisthesis, like forward spondylolisthesis. In here, there is bilateral pars interarticular defect, bilateral pars interarticular defect, anterior slippage of the vertebral body, and most common L5 slips over elbow. There is forward deviation of one vertebra or forward slippage of one vertebra over another. It happens due to bilateral pars fracture, pars interarticular defect. There is anterior slippage of vertebra L5 over S1. There is repetitive back extension and rotation, repetitive back extension and rotation. It happens in back extension and rotation. It happens in the gymnast and the divers. Adolescent growth spurt, adolescent growth spurt. Clinical feature, there is low back pain that is worsened, a low back pain that is worsened by extension. There is radiculopathy as slippage progresses, and palpable step off sign may be present. Very high yield spondylolisthesis, you will get palpable step off sign, palpable step off sign. Palpable step-off may be present in spondylolisthesis. And diagnosis, a lumbar X-ray typically visible on lateral views, activity modification, avoid inciting sports, pain control, and neurologic deficits. Neurologic deficits or symptoms more than 90 days, obtain MRI of the brain or surgical consultation. Obtain MRI of the brain or surgical consultation. What is the likely diagnosis in a child? What is the likely diagnosis in a child that presents with several months of back pain and recent urinary incontinence? Several months of back pain and recent urinary incontinence, and palpable step off at the lumbosacral area on physical exam, that is on listhesis. So low back pain, recent urinary incontinence, and palpable step off of the lumbosacral. It is spondylolisthesis, typically caused by forward slippage of L5, over S1 in pre-adolescent child. This is the spondylolysis, that means pars fracture of the pars interauricularis. Spondylolysis, and spondylolisthesis is forward slippage of L5 vertebra over S1. Forward slippage of L5 over S1. There is spondylolysis, fracture of the pars interauricularis. This is spondylolysis. Spondylolysis is pars fracture. Listhesis is forward slippage of one vertebra over another. Okay, degenerative, degenerative or degenerative osteoarthritis. That means positional relieved with rest. Positional relieved with rest. Mm, Osteoarthritis relieved with rest. Radiculopathy radiates to the leg. Radiculopathy radiates to the leg. Sensory or motor findings positive SLR. Radiculopathy SLR. Radiculopathy SLR. Degenerative relieves with rest. Spinal stenosis. Shopping cart sign relieved with forward flexion. Relief with spinal flexion. Spondyloarthropathy relieved with exercise. Spondyloarthropathy HLB 27, young man relieved with exercise. Prolonged morning stiffness. Spinal metastasis, it is a constant pain, worse at night. Constant pain, worse at night. And vertebral osteomyelitis, focal tenderness. Fever and night sweat, focal tenderness, fever and night sweat. Recent infection, IV drug use, and immunocompromise. Okay, chronic back pain in adolescent. Mm, if it is nocturnal pain, systemic symptom, neurologic finding is spinal cord is involved, new onset scoliosis, tethered cord, spinal dysraphism, spinal dysraphism. There is back or leg pain worse with activity, back or leg pain worse with activity, neurologic finding, weakness, hyporeflexia, new onset scoliosis, lumbosacral cuneus abnormality, chronic multifocal osteomyelitis, nocturnal pain, systemic symptoms, spondylolysis, spondylolisthesis. Happens in the gymnast, pain with extension. And inflammatory arthritis, ankylosing spondylitis, pain worse at rest, and morning stiffness, acroiliac joint tenderness. Okay, acute low back pain, management of low back pain. Acute pain, maintain moderate activity, NSAID or acetaminophen, muscle relaxant, spinal manipulation. chronic pain, intermittent use of NSAIDs or acetaminophen, exercise therapy, stretching or strengthening aerobic exercise, and consider TC and duloxetine. Mm, Secondary prevention, exercise and education. So management of non-specific low back pain, acute. Non-pharmacologic, maintain moderate activity prognosis, heat massage, spinal manipulation, and acupuncture. First line medication, NSAID, naproxen, ibuprofen, and consider acetaminophen. Second line, non-benzodiazepine, muscle relaxation, cyclobenzaprine, tizanidine, opioid, tramadol. Opioid, tramadol not preferred, considered for short course for severe and refractory pain. What is a recommended next step in the management for a patient with chronic low back pain despite use of acetaminophen and as the NSAID? It is exercise therapy. If pain persists after exercise and intermittently acetaminophen and NSAID, patient may benefit from TCA or duloxetine. Back braces are not effective for treatment of lower back pain. Also, acute back pain for less than 4 to 6 weeks without the history of trauma. Look for significant neurologic deficit. If there is significant neurologic deficit, go emergency MRI. What are the significant neurologic deficit? Urinary retention, incontinence, subtle anesthesia, lower extremity weakness involving multiple nerve root compression. If no, then go for, or if no suspected infection present or not, febrile spinal tenderness and IV drug abuse. If it is yes, go for MRI and consider X-ray or ESR. If no, mm, suspected malignancy, current or recent cancer history, systemic symptoms, weight loss, multiple cancer risk factor. If yes, MRI or with ESR. If no, uncomplicated back pain. No imaging needed, continue pain management. No imaging needed, continue pain management. Okay. Now, imaging for low back pain. When we will do imaging in low back pain? X-ray for osteoporosis or compression fracture if there is suspected malignancy, if it is AS, ankylosing spondylitis. MRI if there is sensory or motor deficit, if there is claudication syndrome like urinary retention, saddle anesthesia, if there is suspected epidural abscess or infection, fever, IV drug abuse, concurrent infection, hemodialysis, and radionuclide bone scan or CT scan, indication for MRI but not able to have MRI. What patient are not able to have MRI? Plain flames have lower sensitivity for bone metastasis, but some guidelines suggest X-ray combined inflammatory markers to increase sensitivity for patients with moderate clinical suspicion for malignancy. Okay, acute lumbosacral radiculopathy. Very, very, very high L topic. What are the causes of acute lumbosacral radiculopathy? It may be herniated disc, it may be degenerative spondylosis, maybe malignancy or epidural abscess. There is low back pain radiating to the posterior leg to foot. SLR is positive in lumbosacral radiculopathy. SLR is positive. Cross SLR may be positive also. Positive SLR, cross SLR is positive. There is dermatomal sensory loss or myotomal weakness. Dermatomal sensory loss, myotomal weakness. Diagnosed based on primarily the clinical features, and MRI is recommended if there is any bilateral neurological defect, bulbar dysfunction, saddle anesthesia, if this suspected malignancy or epidural abscess. Activity modification, it does not mean bed rest. First 1 to 2 weeks we can use NSAID. If not improve after 2 weeks, we can use physical therapy and oral glucocorticoid. And after 4 to 6 weeks, obtain MRI and assess for surgical mm, indication. Okay, these are the features of lumbosacral radiculopathy. In L2 to L4 nerve root, patellar reflex is affected. Patellar reflex is affected. Sensory loss, anteromedial thigh, medial shin, anteromedial thigh, medial shin. And weakness is hip flexion, hip adduction, adduction, and knee extension. Hip flexion, hip adduction, knee extension. So L2 to L4, hip flexion, hip adduction, knee extension. That is quadriceps. Quadriceps has four muscle: rectus femoris, vastus medialis, lateralis, and intermedius. And L5, there is no reflex affected. Sensory loss is lateral shin, dorsum foot, lateral shin, dorsum foot. So foot is involves foot dorsiflexion, inversion, foot eversion, and toe extension. S1 Achilles, Achilles reflex, posterior calf, sole and lateral foot, posterior calf, sole and lateral foot, posterior calf, sole and lateral foot. It causes hip extension, hip flexion by the L2 to L4, and hip extension S1 weakness, hip extension, knee flexion, hip extension, the opposite of L2 to L4, like hip extension but knee flexion, and foot plantar flexion, gastrocnemius. In S2 to S4, anconias, reflex affected perineum, urinary or fecal incontinence, and sexual dysfunction. Achilles tendon reflex decreases with age, and its absence is common in the older individual. So what is the next step in the management for a patient with suspected lumbosacral radiculopathy sciatica after lifting a heavy box? SLR test is positive. Neurological examination is unremarkable. Trial of NSAID acetaminophen. Imaging in herniation. Imaging in herniation is controversial as it does not change with management. So therefore, no MRI, just mm, no MRI for just back pain plus positive SLR alone. So therefore, no MRI for just back pain and positive SLR alone. Okay, if there is severe progressive neurologic deficit, we should do MRI. So not just low back pain, we are sending the patient to the MRI. That is a very wrong concept. MRI positive SLR, we do not go or rush for MRI. Okay, most patient, 80% patient will have spontaneous resolution. Should a patient with disc herniation be recommended bed rest? No. Maintain ordinary activities. Disc herniation, not recommended. Only bed rest. Maintain ordinary activity. Commonly tested point. Do not imaging. Study in patients without focal neurological deficit. Okay, what is the likely diagnosis in a patient that presents with back pain after carrying a heavy back package? Back pain after having a heavy back package. Physical examination reveals paravertebral tenderness. SLR is negative. Neurological examination is unremarkable. If there is paravertebral tenderness, SLR negative, looks like lumbosacral strain. Most common cause of acute back pain that does not radiate below the level of the knee. Lumbosacral strain of the paraspinal muscle, tendon, and intervertebral ligament muscle. paraspinal muscle, tendon, intervertebral ligaments. There is sudden or unbalanced muscle contraction, lifting, twisting, risk factor, obesity, spinal deformity, or degeneration, muscle weakness. Clinical feature: pain in lumbar area may radiate to buttock, hip, thigh. It should be lumbosacral strain, should be above knee. If it is below knee, up to heel or foot, that means it is radiculopathy, not lumbosacral strain. There is paraspinal tenderness, no neurologic deficit, negative SLR motor activity NSI, and non-benzodiazepine muscle relaxation. Spinal trauma, pre-hospital, emergency department, pre-hospital, spinal immobilization, backboard, rigid collar, lateral head support, careful helmet removal, and supplemental oxygenation, emergency department, orotracheal intubation, inline cervical stabilization, CT of the entire cervical spine. What is the first step in the cervical spinal trauma? Cervical immobilization. Cervical spine imaging should be performed whenever there is high energy mechanism, high speed motor vehicle collision, fall more than 3 meter, trauma causing concomitant closed head injury. Okay, according to Nexus criteria, cervical spine imaging is necessary if any of the following is present: neurologic deficit, spinal tenderness, altered mental status, intoxication, and distracting injury, long bone fracture. A CT scan of the cervical spine without contrast is preferred screening. A CT scan of the cervical spine without contrast is preferred screening and test to evaluate for cervical spine injury. If none of the next criteria are present, then imaging is not required, like no neurologic deficit, spinal tenderness, altered mental status, intoxication, and long bone fracture. No imaging is required. A normal neurologic examination is sufficient to rule out cervical spine injury. The presence of single vertebra, especially cervical, in a patient with blunt trauma, is an indication of image of the entire spine. CT scan is screening. CT scan is the screening modality of choice because of its sensitivity and accuracy. Okay, that's all about the low back pain and its related topic. Hope you enjoyed.